noir plasma chrome bleed. Unlocking knowledge, inspiring innovation, empowering curious minds.
This website makes learning so easy. I found all my resources here.
Like what you share.
The hyoid bone is a unique, U-shaped bone. It is a floating bone. It does not connect to any other bone. It acts as an anchor for swallowing and breathing. The hyoid is divided into three main parts. First is the body, the central portion. The greater cornua project backward, and the lesser cornua extend upward.
Meet the hyoid bone, the anchor for the neck's heavy lifters. Muscles attach above and below it, forming a dynamic pulley system. They move the larynx and tongue for swallowing and speech.
The suprahyoid muscles elevate the hyoid. The digastric has two bellies and opens the mouth. The stylohyoid retracts it during swallowing. The mylohyoid forms the floor. Geniohyoid pulls it forward.
The infrahyoid muscles are known as strap muscles. They connect the hyoid to the sternum, clavicle, and scapula. These muscles pull the hyoid bone downward. They act to depress the larynx.
Beyond muscles, the hyoid is supported. The stylohyoid ligament suspends it. The thyrohyoid membrane connects it to the cartilage, and the hyoepiglottic ligament connects to the epiglottis. A lateral impact can cause severe middle ear trauma. The tympanic membrane and canal cartilage are displaced, forcing the malleus and incus to dislocate as a fused unit.
Stapediovestibular luxation is an extremely rare trauma. The stapes is driven into the vestibule, causing fluid to leak. This presents as severe hearing loss and
The hyoid bone is a solitary, U-shaped bone in the anterior neck. It is suspended by ligaments between the mandible and thyroid cartilage. Distinct polymorphic variants exist, showing variations in fusion. The hyoid is a highly polymorphic bone. It is unique in that it does not articulate directly with any other bone. Instead, it is suspended within the anterior neck. The hyoid bone consists of 5 bony components. The body is a broad, central segment. 2 greater horns project posteriorly, and 2 lesser horns arise from their junction.
Let's analyze the hyoid bone data across distinct demographics. Mean body height varies significantly, with observed ranges up to 16 millimeters. Anomalies include
reviewing the documented anomalies. Markedly elongated lesser horns in this pediatric case. The anomalies present unique clinical challenges. This requires further investigation. These variations have substantial implications. Anomalies like asymmetric horns can cause dysphagia. An accessory bone may cause a globus sensation. These are easily mistaken for fractures.
the hyoid bone acts as a central anchor. Suprahyoid muscles elevate the larynx during swallowing. This protects the laryngeal inlet from aspiration.
If the hyoid is stabilized, suprahyoid muscles depress the mandible. This assists in wide mouth opening. Anterior belly originates from the biotendon. Posterior belly from the mastoid notch. The stylohyoid muscle. It arises from the temporal styloid process and inserts onto the lateral body of the hyoid. It is innervated by the facial nerve. It pulls the hyoid upward and backward. The mylohyoid muscle forms the floor of the mouth. Arising from the mandible, it inserts onto the hyoid bone. Innervated by the trigeminal nerve, it elevates the floor of the mouth during swallowing. The geniohyoid is a narrow, paired muscle. It runs from the mandible to the hyoid bone. C1 fibers hitchhike along the hypoglossal nerve to innervate it. It pulls the hyoid forward, expanding the airway.
The infrahyoid muscles lie inferior to the hyoid bone. They depress the hyoid after swallowing. They also stabilize it for tongue and jaw movements.
The sternohyoid is a superficial strap muscle. It originates from the manubrium and the clavicle. It inserts onto the inferior border of the hyoid. It is innervated by the ansa cervicalis, C1 to C3.
Located deep to the sternohyoid, it originates from the posterior manubrium and inserts onto the oblique line of the thyroid cartilage. Innervated by the ansa cervicalis, it acts to depress the larynx.
The omohyoid is a two-bellied muscle. It is innervated by the ansa cervicalis. This action keeps the internal jugular vein open, maintaining low venous pressure and assisting blood return to the heart. The thyrohyoid is a short strap muscle. It connects the thyroid cartilage to the hyoid bone. It is innervated by C1 fibers riding with the hypoglossal nerve. With the hyoid fixed, it elevates the larynx. Due to its unique location, suspended by muscles and ligaments, the hyoid bone is highly significant in cases of manual strangulation. Fractures can occur with as little as 2.5 pounds of pressure. Fractures typically occur through two distinct mechanisms. Direct lateral compression forces the greater horns inward, leading to fractures near their posterior third, occurring in up to 73% of manual strangulations.
Manual strangulation causes direct compression. Hanging results in indirect traction. Ligature strangulation involves mixed forces. These are key forensic parameters.
In forensic pathology, the level of neck constriction is a key parameter. For manual strangulation and hangings, it's typically above the thyroid cartilage. Ligature strangulation usually occurs at or below it.
In forensic pathology, the hyoid bone is critical. Throttling shows an extremely high fracture rate. Hangings and ligature strangulate 23%. This fracture prevalence distinguishes the mechanism of injury.
For manual strangulate with 3D MIP is best. Hanging cases require detailed multi-slice CT, and for ligature tracking, we use CT angiography. These modalities provide critical forensic evidence.
During development, the thyroid begins at the base of the tongue. It descends through the neck, forming the thyroglossal duct. The path forms an epithelial canal. Normally, this duct completely atrophies. Persistent duct cells produce fluid, forming a cyst. These present as painless, mobile, midline masses. They characteristically move upward. This occurs when the patient protrudes their tongue.
Historically, simple cystectomy had high recurrence rates, ranging from 45% to 55.6%. This is due to microscopic ductules branching from the main tract.
The cyst trunk procedure is the gold standard approach. It requires an en bloc resection of the cyst, including the central third of the hyoid bone. This reduces recurrence to less than 3 to 10%.
The hyoid is supported by critical ligaments. The stylohyoid suspends it from the temporal bone. The thyrohyoid membrane connects it to the thyroid cartilage. The hyoepiglottic helps pull it closed during swallowing.
The hyoid bone is vital for an open airway. In sleep apnea, the collapse occurs behind the tongue. Hyoid suspension secures this bone forward. This procedure prevents airway collapse during sleep.
The hyoid's position directly influences the volume of the airway. If the mandible is retroposed, the hyoid bone is displaced, draws the tongue base closer to the pharyngeal wall. This narrows the retroglossal space.
For severe OSA patients with airway collapse, hyoid suspension pulls the hyoid bone forward, advancing the tongue base and tensing the pharyngeal walls, widening the airway to prevent collapse during sleep. Hyomandibular suspension. Hyomandibular suspension. Pulled anterosuperiorly and secured to bone screws on the inner surface of the mandible. Studies show hyomandibular suspension yields superior outcomes. It displaces the tongue base. Combined with palatal surgery, it can reduce the AHI by more than 60%, improving oxygen levels.
Like what you shared.
This website makes learning so easy. I found all my resources here.
Noir plasma chrome bleed. Unlocking knowledge, inspiring innovation, empowering curious minds.